This video shows you how to do pre-procedure CT planning using the Redo TAV app. Our index TAV is Evolut and the second TAV is SAPIEN 3 or MyVal. When you click Redo TAV CT planning on the home screen, first you will get the overview of all steps you need to do. The CT acquisition protocol can be the same with routine pre-TAV assessment. It's recommended to obtain an ECG-gated multiphasic function CT that covers the entire cardiac cycle, with ideally 20 phases, a minimum of 10 phases. The mid-diastolic phase generally has fewer artifacts, allowing for better assessment of the processes reflex and commission alignment in most patients. The end systolic or end diastolic phases could be used as alternatives. The first step is index TAV and measurement. If a pre-index TAV CT data is available, select native valve morphology and severity of calcification, and identify your patient index TAV type and size. And then you will get the fundamental information of the valve. Please keep in mind that this light blue eye mark is a link to some detailed information. The reference levels of Evolut is node, counting from inflow to outflow. The leaflets of Evolut start at node 3 and end up at node 6 to 7 for site 26, 29, and 34, and up at node 5 to 6 for site 23. On the next page, select the index TAV failure mechanism and assess commission alignment. Open your patient CT dataset on a CT software. We can use any CT software. We just need 3D MPR, multiplanar reconstruction module. We are now at end diastolic phase, 95%. So first we need to determine the appropriate cardiac phase with less artifact. So now I change the cardiac phase, and for this case, mid-diastolic phase around 75 to 85-95% is the best cardiac phase for this case. So I choose 85% and make sure MPR is aligned to be orthogonal to the valve. And assess commission alignment, which refers to the relations between the native aortic valve commissure and THB commissure TAV. The commissure offset is directly measured using an angle tool with the limb aligned with the native commissure of the RCC and LCC and the THB commissure. In this case, the angle is 59 degrees, so select severely misaligned. And perform the measurement of area and perimeter. These measurements will be used for second TAV sizing later. We can also understand how much the index TAV is underexpanded at this point. For Evolut, 6 levels require assessment, from node 6 to node 1. Here is the node 6 level, and making sure the MPR is precisely orthogonal to the valve, and measure the area by tracing the center of the stent frame because of less blooming artifact. Adjust the tracing if needed, and save the measurement into the report. Next, here is a node 5, and again trace the area by tracing the center of the stent frame. and move to the node 4. So at this time, I just adjust a little bit, and then move to the node 3. Keep the alignment of the ampere to be orthogonal to the valve. And measure the area, again by tracing the center of the stent frame. Some tips to reduce the blooming artifact. I would recommend to down the window level. Now I'm adjusting the tracing. And finally, at the node 1 level, after or during the measurement, please fill in the area and perimeter in the app. Step 2 is identify your patient coronary risk plane, which is defined as the lowest level of coronaries in relation to the node of Evolut. On the CT, we are now at the inflow level. So scroll up the plane, and first you see the bottom of LCA. And identify the relative relation with the node. So the bottom of LCA is just at the node 4, counting from the 0, 1, 2, 3, 4. So just at the node 4. And next is RCA. Now we see the bottom of RCA, and this level is between node 4 and 5. So if the bottom of RCA or LCA between the node, please choose the lowest one. And in the app, select the node level for both RCA and LCA. And the coronary risk plane will be automatically identified in the app. At the step 3, once you select the second tab, you will get an idea about ideal or acceptable level of neoscat plane, NSP, which is defined as the top of the neoscat. For MyVal or SAPIEN 3 in Evolut combination, it is multiple levels between node 4 to 6 for Evolut site 26, 29, and 34, and between node 4 to 5 for site 23. This is because the leaflet nadir of Evolut start at node 3, so to treat degenerated leaflet, we need to implant at least node 4. But as you can see here, at this position, we would admit significant degree of leaflet overhang. And if we implant higher, like node 6, there would be less, almost 0 degree of leaflet overhang, but it can increase the risk of coronary obstruction or poor coronary access. Based on such understanding, you will choose neoscat plane where you would like to implant. Here is some guide how to proceed from here. We would recommend to assess at all possible neoscat plane and save the summary report for each level. As second tab sizing and coronary risk may change according to the neoscat plane. The lowest neoscat plane, which is node 3 for Evolut, should be used only for pure aortic regurgitation. Since at this implant position, a second tab will not pin out the index tab at all. Last but not least, when the reason for Redo TAV is paravalvular leakage, please make sure the second tab will cover the annulus level since node 6 implantation may not cover it. So I will start with node 6. The neoscot plane at node 6 will be above the coronary risk plane, both coronaries in this case. So we need further coronary assessment. But remember that a balloon expandable second TAV can expand index TAV, which means reduce valve to aorta distance, increasing coronary risk. Then we need to determine the second TAV size first. Step 5 is in vivo CT sizing. For MyVal or SAPIEN 3 in Evolut combination, using the average area as the neoscot plane you choose, and 3 nodes below is recommended so far. We already measured the areas and perimeters at step 1. On the app, the 4 levels, according to the neoscot plane you choose, will be automatically selected. So please make sure the numbers are correct. And if you would like to, check the bottom of Include Perimeter and click the Calculate. Then you will get calculated average area, perimeter area driver diameter, perimeter driver diameter. The app cannot suggest sizing at this point due to the FDA regulation. So you will need to choose the second TAV size based on your CT measurement. Here has some guide how to choose size. And here you can get IFU table too. For this case, I will choose size 23 SAPIEN 3. And move to coronary risk assessment with the size you choose. As I mentioned, SAPIEN 3 or MyVal is a balloon expandable valve and can expand the index TAV further. So we would recommend to draw the virtual circle of the size you choose for the second TAV and measure valve to aortic VTA distance from the virtual circle or index TAV stent frame, whichever is outer, and identify the northwest VTA distance in the zone from the neoscot plane to the coronaries. When the neoscot plane is above the SG junction, please don't forget to assess VT-SJ. In the app, the relationship between the neoscot plane and each coronary is automatically identified. When the neoscot plane is above RCA or LCA, the next assessment is the relation between the neoscot plane and SG junction. I would recommend to assess RCA and LCA separately and fill in the app. Let's start with RCA. So first, bring the plane at the node 6. And the level of node 6 is above the SG junction. So we need to measure the VT-SJ. From the virtual circle of the size you choose for second TAV or index TAV stent frame, whichever is outer. In this case, the stent frame of index TAV is outer, so measure the VT-SJ from the index TAV stent frame, which is 1.6 mm, and scroll down. Then assess the VT aortic sinus. Still, the index TAV stent frame is outer. And scrolling down further, and now is at the VTC valve to coronary, which is 5.6 mm. And fill in the app. The next is LCA assessment. So again, bring the plane to the node 6 first and assess the relation with the ST junction. So node 6 at the LCS side is just at the ST junction. So we measured the VT-SUJ, which is 1.9, very narrow. And scrolling down, now is VT aortic sinus. And scrolling down further, now VTC. Still, the index TAV stent frame is outsider than the virtual circle. And once you fill in such VT-SUJ, VT-LOS, and VTC, the app automatically will identify the narrowest VTA values. Therefore, in this case, the implantation at node 6 is considered as a high risk to coronary because less than 2 mm VT-SUJ distance, which means high risk to sinus sequestration. In the app, you will get summary report of 3 pages, which include animation representing the relationship between the neoscot frame and both coronaries. You can take screenshots and also import these reports into CT software summary report, such as Dimensio. So, in the report page 2 or 3, you can see the assess at different NSP level. So click this one. The bottom will bring you back to step 4. Choose neoscot frame. Let's assess at node 5 next. The node 5 neoscot frame will be still above the coronary risk frame in this case. So before coronary risk assessment, determine the second TAV size. Now you chose node 5. So the app automatically selects node 5 to node 2. Then based on the average area, you choose the second TAV size. Now you notice that the average area is larger than what we got when we chose node 6. Based on this average area and the IFU table, I will choose size 26, which is one size larger than that for node 6. And move to the coronary risk assessment with the size. The methodology is the same with what I showed before. Now we change the second TAV size. So, need to change the virtual circle size. On the CT, we adjust down the BTC measurement of the LCA. So let's start with the LCA side. First, bring the plane to the node 5 and assess the ratio with the ST junction, which is now below the ST junction. And just at the VTC. So we just need to measure the VTC. Change the virtual circle to the 26, which is the size we choose, and then measure the VTC distance from the virtual circle, which is now outer than the index TAV, which is we got the 7.1 mm for the VTC distance. Next is the RCA. So bring the plane back to the node 5, where is below the ST junction and just at the coronary level. So we just need to measure the VTC, which is now 41 mm. And then you will get the summary report for the neoscot plane at node 5. Lowering the neoscot plane from node 6 to node 5 will decrease the risk of sinus sequestration. And now at this implant position, risk to coronary is considered as low. Lastly, let's check at the node 4 neoscot plane. Click the assess at the different neoscot plane level. And we comes back to the step 4. So click node 4. The neoscat plane at node 4 will be at or below the coronary risk plane, the bottom of both coronaries. Do the same steps for CT sizing. The average area is larger than that at node 5, but still within the range of site 26. So I will choose 26 SAPIEN 3. Now the neoscat plane at node 4 is below the coronary risk plane, so no need for the coronary risk assessment by PTA. Then you will get the summary reports of 3 pages for this neoscat plane level. If available, the information of pre-indexed TAV CT can be gathered at step 8. This information can help your planning more. Here are the summary reports for all neoscat plane levels. For this case, I would target node 5 or node 4, because this implant position will be low risk to coronary obstruction. If we would like to secure future coronary access, node 4 might be better, but more leaflet overhang. It is also important to note that if a case has severe calcified leaflets, and even if we implant SAPIEN 3 at node 4 or 5, the leaflets might pin out to node 6 and lead to sinus sequestration. So please also assess the severity and distribution of the leaflet calcification and consider coronary protection if needed. This is all steps for SAPIEN 3 or MyVal in Evolut combination. I hope this video helps you planning Redo TAV. Thank you.